alaikum. Welcome, doctors and my fellow colleagues, to our journal club of 5th-year medical student in Libyan International Medical University. Thank you for coming to our presentation, which will be presented by myself, Sara Yusuf Al-Houni, and my colleague, Safa Al-Atrash. The first part, I'll discuss the burden of obesity, and later I'll try to demonstrate the medical and surgical approaches in its treatment. As we know, obesity is a worldwide health problem. The WHO has defined the obesity as an abnormal accumulation of excessive fat that put patients in a risk. A patient with a body mass index more than 30 kilogram per meter square is considered as an obese, while a patient with 25 body mass index is considered as an overweight. The prevalence of obesity and overweight have reached an epidemic proportions in the last decades. With estimates by the WHO pointing that about 2 million people are at least overweight worldwide. Obesity can be caused by a lot of factors. First of all, physically inactive people who living a sedentary life, people who overeat. Genetics also can play a role in causing obesity. Frequency of eating. Study shows that individuals who eat five meals per day, 5 small meals per day, they maintain their normal weight. There's a lot of medications can cause obesity, such as antidepressant and anticonvulsant, and as we know, cortisol too. Psychological factors such as depression and stress. Some medical conditions, specifically endocrine conditions such as hypothyroidism and Cushing's disease. Complications of obesity. There's a lot of complications for obesity. It can be complicated to type 2 diabetes mellitus, heart diseases, high blood pressure, and certain cancers such as breast in female, colon, and endometrial. Can cause also stroke, gallbladder diseases, fatty liver disease, and high cholesterol, sleep apnea and other breathing problems, and can also cause arthritis and infertility. The medical approaches in treating obesity: diet and exercise, behavioral changes. It's ineffective in long term. Less than 5% sustain significant weight loss, which is insignificant for obese patients. The second choice is weight loss drugs. Doctors usually prescribe for obese patients drugs such as orlistat and phenetramine, which reduces the appetite. These induce minimal sustained weight loss, and they cannot use it in long term due to their side effects. Nowadays, there is a new option called bariatric surgeries. In this field of medicine, composing the study of obesity, it causes, prevention, and treatment. Bariatric surgery is a therapeutic intervention to understand and treat the causes and sequelae of morbid obese. Bariatric surgery is coined from a Greek root. It means that large or obese. So why are you choosing surgery? Diet and exercise are not effective long-term in the morbidly obese. Also, surgery is an accepted and effective approach. Medical comorbidities are improved and some of them are resolved, such as hypertension, infertility, increased life expectancy, decreased health care costs, and surgical risk is acceptable versus risk of long-term obesity. So who is surgical candidate? A patient or obese individuals with BMI more than 40 kilogram per meter square, or individuals who have 35 kilogram BMI of 35 kilogram per meter square and combined with a complication. And those who have failure of other approaches to long-term weight loss, and individuals who aged between 18 and 55. How does bariatric surgery works? It works by two mechanisms, which is restrictive and malabsorption. Restrictive surgery is used to physically limit the amount of food that the stomach can hold, which limits calories consumptions. The common examples of these surgeries are Roux-en-Y gastric bypass and sleeve gastric bypass, where I'll talk about every single procedure. And the second mechanism is malabsorption. Surgery is used to shorten or bypass part of the small intestine, which reduces the amount of calories and nutrients the body absorbs. The most common examples are biliopancreatic diversion with duodenal switch and mini gastric bypass. In bariatric surgeries, the procedure is typically performed laparoscopically, which involves inserting a small instrument through multiple small incisions in the upper abdomen. This is one of the most common restrictive surgeries, Roux-en-Y gastric. In Roux-en-Y gastric bypass, surgeons create a small pouch at the top of the stomach. The pouch is only part of the stomach that receives food. The small intestine is then cut a short distance below the main stomach and connected to the new pouch. This greatly limits the amount that person can comfortably eat and drink at one meal. The other example is a sleeve gastrectomy. Sleeve gastrectomy, about 80% of the stomach is removed, leaving a tube-like structure, which the only part of the stomach that receives food. The smaller stomach cannot hold as much food. It also produces less of the appetite-regulating hormone, ghrelin, which lessens the desire to eat. Biliopancreatic diversion with a duodenal switch. It's an example of malabsorption surgery. First of all, surgeons, they do sleeve gastrectomy, as I said, by removing 80% of the stomach. And then the small intestine is then divided at the duodenal and rerouted so that the ileum connected to the pylorus, bypassing the duodenum, as we can see here. The last example, which is mini gastric bypass. In this surgery, surgical process in which a small pouch is created, as in sleeve gastrectomy, in the top of the stomach, which a gastroenteric anastomosis, and then surgeons, they do gastroenteric anastomosis in the pre-colic esoperiostalic loop, 200 centimeters from the duodenojejunal angle. Thank you. And now we will move on to the second part, which will be discussed by my colleague Safa about the review studies of bariatric surgeries in metabolic disorders. Thank you.
Assalamu alaikum. Now I'm going to present a review study about bariatric surgery for obesity and metabolic disorders done by Diabetes Surgery Institute. Okay, they reviewed that bariatric surgery for severe obesity is an effective treatment that results in long-term weight loss and improvement and remission of many obesity-related comorbidities, as well as improvement in quality of life. Type 2 diabetes is most studied metabolic disorder associated with obesity, with data demonstrating that improvement or remission of type 2 diabetes in obese patients was superior after bariatric surgery compared with conventional medical therapy. They reviewed also there is a variability in the rate of diabetes improvement or remission seems to exist between types of bariatric surgery. Indeed, biliopancreatic diversion with a duodenal switch has the best results with 95% of diabetes resolution, followed by Roux-en-Y gastric bypass with 80% and laparoscopic adjustable gastric band with 56%. In meta-analysis with 19 studies and 11,175 of patients who had type 2 diabetes and had underwent bariatric surgery has remission of 86.6% of patients. In 2011, biliopancreatic diversion with the duodenal switch compromised more than 1% of all bariatric procedures performed in the USA. Okay, now what are the effects of bariatric surgery in remission of type 2 diabetes? They reviewed the two main hypotheses. The first one, the hind-gut hypothesis, which enhances the incretin effect, while the foregut hypothesis, which reduces or suppresses the secretions of anti-incretin hormones. So what is incretin effect? This is an easy format to show you how incretin effect works. Incretins, which are hormones, a glucagon-like peptide, one, and the glucose-dependent insulinotropic polypeptide. These hormones that stimulate insulin release and inhibit glucagon release for lowering of blood glucose. And also these hormones are activated by DPP4 enzyme. In type 2 diabetes remission and improvement, several studies done by different associations and universities. The first one in 2011, study was done by Diabetes Surgery Institute in a group of patients who were followed up for 1 year. 90% of patients in medical therapy group had met the triple endpoint, glycated hemoglobin less than 17%, and LDL less than 100 milligram per deciliter, while systolic blood pressure less than 130 millimercury, compared with 49% in patients enrolled in gastric bypass. The second one in 2014, a study was done by University of Pittsburgh, and a group of patients were followed up for 3 years. The remission of type 2 diabetes was achieved in 40% of patients in gastric bypass group, compared with 29% in patients of laparoscopic adjustable gastric banding, while the remission in medical therapy group was 0%. In the same year, the other study was done by Cleveland Clinic, reported that the remission was 46% enrolled in gastric bypass group, compared with the 29% in laparoscopic sleeve gastrectomy, and medical therapy group, the remission was 0%. In 2015, a study was done by a group of researchers in Catholic University, which reported that the glycated hemoglobin was less than 6.5% without glucose-lowering drugs in wrong gastric bypass group, compared with 68% with duodenal diversion group, and 0% in medical therapy group. The last one in 2016, a crossroad trial, were performed in a group of patients, reported that the remission was 60% enrolled in gastric bypass group, compared with 6% in medical therapy group. Okay, many recommended medical guidelines by several associations and colleges. The first one in 2011, International Diabetes Federation recommended that bariatric surgery is appropriate treatment for people with type 2 diabetes and obesity. In 2011, American Heart Association, American College of Cardiology, the Obesity Society recommended that bariatric surgery could be appropriate option to improve health in adults with body mass index more than 40 or less than 35 with obesity-related comorbidities conditions not responded to behavioral treatment. In 2015, American Association of Clinical Endocrinologists and American College of Endocrinology recommended that bariatric surgery should be considered in patients with severe obesity and obesity-related complications. The last one in 2015, 3 recommendations were made regarding bariatric surgery by American Diabetes Association. Firstly, bariatric surgery could be considered for adults with body mass index more than 35 and type 2 diabetes, especially if type 2 diabetes associated comorbidities are difficult to control with lifestyle and pharmacological therapy. Second one, patients with type 2 diabetes who have undergone bariatric surgery need lifelong lifestyle support and medical monitor. The last one, small trials have shown glycemic benefit of bariatric surgery in patients with type 2 diabetes. Okay, in addition to type 2 diabetes remission, bariatric surgery have also showed improvement or remission of other metabolic syndromes such as hypertension, hyperlipidemia, and even obstructive sleep apnea. In systemic review and meta-analysis was done between 1990 and 2003, found that hyperlipidemia improved in more than 70% of patients, hypertension in 78.5%, and the sleep apnea 83.6% of patients who had received surgery. Another retrospective study was done by Mayo Clinic reported that the outcome of 180 patients who underwent gastric bypass compared with 157 patients who underwent weight reduction program for metabolic syndrome at mean follow-up of 3 years, the prevalence of metabolic syndrome decreased from 87 to 29% after bariatric surgery compared with 85 to 75% after medical weight reduction program. Okay. In summary, obesity continues to be a worldwide health problem. Bariatric surgery is safe and effective long-term treatment for obesity that results in long-term weight loss, improvement or remission of obesity-related comorbidity, especially type 2 diabetes, and improvement in quality of life. The most effective bariatric surgery in the treatment of type 2 diabetes is pilopancreatic diversion, had the best results with 95% of diabetes resolution. The most common bariatric surgery performed in the USA or worldwide is the sleeve gastrectomy. Now, new minimally invasive procedures and lower body mass indications will probably increase the adoption of surgical treatment for obese patients. At the end, these are our references, and thank you for your attention.